Hello, everyone, and welcome back to another session with Dental Shadowers. Today, we have a very exciting session with Dr. Roth. Dr. Roth, thank you so much for joining. And on that note, the floor is yours to take away.
Excellent. Thank you very much. And thanks for letting me speak with you all. My name is Dr. Stephen Roth. I am a diplomate of the American Board of Oral and Maxillofacial Pathology. And I am an oral and maxillofacial pathologist, which I'm sure many people that are watching this may not be familiar that this even exists. I know I certainly didn't when I was pre-dental. But you can see my socials there. I just started a Instagram page and then also an educational YouTube. So if you're watching this on YouTube Live, when you're done, you can hop over and watch some cringy videos of me doing some educational oral pathology stuff. So just a little bit about my background. So I grew up in Ohio, and I went to Ohio State for undergrad, and I come from a family of either teachers or healthcare workers. So my grandmother was a high school teacher, but my grandfather was a pharmacist. Both my parents are optometrists. My aunt's a pharmacist, and then my sister's a teacher as well. So you, I guess, had two options in my family. You were either going to teach or go into healthcare, but not a real doctor, if you will. Um, anyway, so I did undergrad. There's a picture of me, homecoming court at Ohio State, which is a really cool experience. And then stayed on for the next 4 years for my DDS, which you can see me there with Brutus Buckeye, the mascot. And then I did a 3-year residency, which oral and maxillofacial pathology is a 3-year residency at Northwell Health Long Island Jewish Medical Center. You can see a picture right there. It's a really cool building. In fact, they've used it in a lot of TV shows. So Madam Secretary has filmed there. If anyone watched a really awful Netflix movie with Adam Sandler and Chris Rock, they did like a Adam Sandler's daughter was marrying Chris Rock's son, and Chris Rock was this fancy surgeon, and they filmed in my hospital. That was my first year of residency. So Adam Sandler and Chris Rock were just walking around the hospital like my first month of residency. And then also really cool recently, the first COVID-19 vaccine in the United States was given to a nurse at my hospital. So Sandra Lindsay, who you've seen pictures of getting the first vaccine, the Pfizer vaccine, was a nurse or is a nurse at my hospital. So I see her all the time walking around the hallways. And then I was very fortunate that I now continue there. So I graduated last July. And if anyone on the call graduated from high school or graduated from undergrad or graduated from a master's program, you know that graduating in 2020 was not a pleasant experience. But fortunately, things worked out in the end. And in January of this year, I started at the residency program where I trained, and now I'm there full time, which is really awesome. So what the heck is oral and maxillofacial pathology? And I did follow kind of, I was very fortunate to be given a guide from the organizers to help plan this. And I watched a few videos before to figure out what other people said. And it's funny to hear people talk about general dentistry. And I'm sure you've heard what is general dentistry a million times, but some of you may not actually know what oral and maxillofacial pathology is. So oral maxillofacial pathology is a specialty of dentistry, and there's only about 250 practicing in the entire United States. So it's a very, very small specialty, and we kind of all know each other, which is really cool. It's a really small community that's really well connected. It's a specialty just like endodontics that does root canals, orthodontics that does braces, periodontics that does gum disease and works with gum and bone. But pathology is its own little thing. Most oral maxillofacial pathologists are in dental schools, and they have teaching responsibilities on top of their practice in dental schools. Some, like myself, are in hospitals. If I were to guess, I'd say maybe 10% or so are in hospitals. And then a select few that you could probably count on two hands have a private practice. And the purpose is to diagnose conditions in the oral cavity. And some oral maxillofacial pathologists do this in patients. So they look in patients' mouths and they look at kind of the weird stuff that can happen in patients' mouths. And some look at biopsy specimen under the microscope. So an oral surgeon, an endodontist, a periodontist, a general dentist might take a little piece of tissue, and then we can look at it under the microscope and try to come up with a diagnosis there. So This is obviously outside of the routine, cavities, treating cavities. This is more of cancer, autoimmune diseases, infections, allergies, and things along those lines. In fact, I often joke that as a dentist, I was so focused on the teeth that I often didn't pay much attention to everything around the teeth. And now, as an oral maxillofacial pathologist, I'm focusing on everything but the teeth. And so sometimes I have to actually count the tooth numbers. I go, okay, 1, 2, 3. Oh, okay, it's a premolar, because I don't use teeth numbers very often in my practice. And people in oral maxillofacial pathology kind of split their time amongst these three major sections. And I left one out. Research is a big component, and there are some oral pathologists that only focus on research. I don't focus on research at all. I don't really do any research, so I didn't include it. But a lot split their time between teaching, microscopy, looking under the microscope, and patient care. So here I've got a nice little YouTube video from my YouTube channel, another plug. This is a dermoid cyst that I looked at under the microscope, and this is a really cool patient case that I saw. This is a deep fungal infection, a very rare fungal infection called histoplasmosis. So where do I lie? Well, kind of over here. I do some teaching. And before I got my full-time position at the hospital, I was teaching part-time at a dental school in the tri-state area called Toro College of Dental Medicine. It's a newer dental school, and I was teaching there and still do teach there a little bit. Also was supervising a clinic at a dental hygiene school. But now that I'm faculty at the hospital, I kind of do less teaching. We do have the residency program where I graduated, so I do have some teaching responsibilities for the residents, but most of my time is looking under the microscope or looking in patients' mouths. So this is kind of my dot in my triangle of activities. I do want to mention, because I didn't before, I heard Ibrahim talking he's from Jersey, before my computer shut down. But for those not familiar with New York, like I was definitely not familiar with New York before I came. New York City is actually more than just Manhattan. A lot of people think of New York City as being Manhattan. Manhattan is this island right here. It is one of the 5 boroughs. We also have Staten Island and the Bronx, Brooklyn, and Queens. And the hospital where I work is actually on the Queens and Long Island border. So this is Long Island. That's you might hear about the Hamptons and other things like that on Long Island. That kind of goes beyond Queens. And so my hospital's right on the border of New York City and the suburbs. So it's really cool because we get a really diverse patient population. And there actually are quite a few oral pathologists in the tri-state. And by quite a few, I mean like 6. That's actually a lot. But my patient practice, I see people from Manhattan, from Brooklyn, from Queens, and then I also see people from the Hamptons. So it's a really unique, diverse patient population. And I see a little bit of everything. Oop. So what kind of complaints do people present with to my practice? The vast majority of patients that I see have either burning mouth syndrome or lichen planus. Burning mouth syndrome is a really interesting thing. I could probably spend about a half hour talking about it. I do have a YouTube video if you want to go watch and learn more, but it's a really interesting condition where patients have burning in their mouth, but when we look, they have no visual change. So the burning, there's something going on with the nerves that causes this burning, and you have to rule out other things that may be happening. The second most common thing that I see is a condition called lichen planus, and that's what I actually have a picture of here. This is a chef for a hotel on Long Island, and he had lichen planus. And lichen planus is similar to a rash. And in fact, this patient had it on his hands as well, his hands, his elbow, his knees, and also had it in his mouth. And you get this kind of really painful ulcer in the mouth, and we can treat that. And then, of course, patients that come in with a bump or a growth or a white patch, they'll say that they have a sore in their mouth or it hurts to eat. Or very commonly, my dentist or dental specialist told me that I needed to see you. So we are kind of a tertiary care person where it's really cool that dentists will send to us, oral surgeons will send to us, periodontists will send to us when they don't really know what's going on. So it's really awesome to kind of be that go-to person where a lot of people rely on you for your experience and knowledge. So what's a typical day for me in oral pathology? Usually there's some sort of resident educational activity. So sometimes we'll read journal articles and discuss them. Sometimes we'll look at challenging cases under the microscope that we get from other institutions. And that's a really good learning opportunity where other institutions will send really rare or really interesting cases, and we have to kind of try to figure out what it is. And then we go through our microscopic biopsy sign out. So we get biopsies sent from clinicians, mostly in the tri-state, but all over. We get biopsies from California, from South Dakota, from Vegas, from all over. And that gets processed. And then the next day, we look at them under the microscope and we deliver a diagnosis for those patients. And the light days will typically be around 20 biopsies. But Mondays, which include biopsies that we receive in the mail Friday and Saturday, we can be looking at 100 and 125 biopsies. We look at about 11,000 to 12,000 biopsy specimen a year, which is quite a lot. We're a pretty big biopsy service, one of the biggest in the country. So after the resident educational activity and the signing out the biopsies, my day is kind of a variety. Some days I have patient care activities where I have my own patients that come in and I'll see them. Sometimes I'll have scholarly activity where I am either teaching or giving a lecture, or I'm writing up a case report. I'm getting ready for a conference. I'm listening to lectures from experts all over the country to make sure I'm staying on top of my game. Sometimes we'll get patient consults from the hospital floor or from the emergency department, where patients come into the emergency department and they're in a lot of pain, or they've got a weird thing in their mouth and we get called. Sometimes we do what's called frozen section. So if anyone has listened in to an oral surgeon that does operations in the OR, sometimes if they do an operation where they're cutting out cancer from someone's mouth, they submit it to us. And at the time of the operation, we can look at it under the microscope and tell them if there's cancer in their margin. So they know that they need to go back and cut more of the cancer away. It can also be diagnosis too. So if they're like, I don't know what the heck this is, they can send it to us while the patient's still asleep in the operating room, and we can give them or attempt to give them an answer as to what it is. And then there's also a lot of practice management. So clinicians calling and saying, can you explain to me what this biopsy means? Sending out slides to other institutions, getting presentations ready, getting biopsy specimen ready. We send out a bunch of formalin, which is what people put biopsies in, a bunch of forms out to our clinicians so that they can send them back to us. And so it's a variety of different things. So based on the day and based on what needs to be done, it's always something different. And we are very busy. I put in a lot of time, but it is a lot of fun. We see a lot of variety, and there's always something weird because we are kind of the last people to be seen. It's always some weird case that comes to us where either under the microscope, it's some kind of crazy, weird thing that we don't know what it is and we have to try to figure it out, or some patient with some weird lesion in their mouth that we got to figure out. So it's really very exciting. So what kind of procedures do we do? I listened to a few general dentists that were talking about their really cool scanner machines and their latest technology. This is my technology. It is a disposable mirror and a piece of gauze. I would say for 90% of my patients, that's all I use. That and my hands and my eyes. So I use a mirror and some gauze, and I do an exam. Most of my appointment time is me getting medical history from the patient, getting their chief complaint. How long have they had it? Has it changed? Who have they seen? What have they thought? Have they had a biopsy? And then counseling them. So this is what I think this is. This is what I think we should do about it. It's a lot of talking. And sometimes I joke that I feel like I'm not an oral pathologist, I'm an oral psychologist, because it's a lot of reassuring people and telling them like, no, you're gonna be okay. And if I am worried, then I do a biopsy. So I do soft tissue biopsies in my patients. So a little advice for dental students, and I do want to kind of rewind to my story and how I got to oral pathology. So I did mention my family is a healthcare predominant family, and I always knew that I liked science. In high school, I loved biology. I actually took anatomy over AP physics because I could have got the AP physics and bumped up my GPA for college, but I had an interest in anatomy and biology, and I knew that it would be helpful for college when I'd go on to be a biology major and hopefully into a medical profession. And so I took anatomy in high school and loved it. Did biology in undergrad. Again, loved anatomy. I was an anatomy TA at Ohio State, which was really cool. I got to do cadaver dissection as an undergrad, which a lot of people don't do until they're a dental student. And I loved my biology courses. And kind of everyone I knew was going into med school. And I kind of didn't want to be like everybody else. I kind of wanted to do my own thing. Everyone was talking about how great dentistry was. All the dentists that I had, like, were really pushing me to go into dentistry and they loved it. I went in as a pre-dental major because I thought that's what I wanted to do. Interestingly enough, I actually shadowed a pathologist, a general medical pathologist at a community hospital in undergrad, and didn't want to do it because he like was in a dark room with organs all day, cutting up organs, and didn't have any like patient interaction. And that would make me go nuts. I would need to like see people. Um, and so I went to dental school. And I found in my second year of dental school that I hated general dentistry. And I'm not saying this to scare people. The world needs good general dentists. I have plenty of dental friends that love dentistry, but dentistry was not right for me, 100%. And I actually considered in the beginning of my D2 year dropping out and going to medical school, taking the MCAT and starting all over again. But interestingly enough, there was the Association of Women Dentists. That was an organization at Ohio State. And Ohio State had a lot of different residency programs, different specialty programs. And the AWD had a lecture series where the program directors came and talked about the different specialties. And so I was like, you know what? This pathology thing, I shadowed a pathologist before. Let me see what oral pathology is all about. And so I went and I listened to it and I'm like, yes, this is it. This is not so, dentistry is very mechanical. It's a little bit more artistic than I thought it would be. And oral pathology is a lot more sciencey. It's a lot more diagnostic. And to me, it was more of a puzzle. It was more of a mental challenge. Whereas dentistry certainly has its challenges, but sometimes it doesn't require a lot of really deep thinking and a lot of really important contemplation. And oral pathology does. If you don't know what something is, you got to hit the books or you got to try a few different tests to try to get to bottom of it. I like to say that my goal in life is to be like House. If anyone has watched House, where he just comes up with the answer in these crazy cases. I don't want to be an asshole like he was, but I do admire his intelligence and his ability to, as a diagnostician, a fictional diagnostician. So I shadowed that oral pathologist who set me up with what my mentor at Ohio State, who really took me under her wing. I shadowed her patient practice. I sat with her at the microscope as a dental student, and I knew that that's what I wanted to be. And so that's kind of, I'll get to kind of some advice at the end, but that's kind of my background. This is more for the general dental school. I do want to say that I think that probably most of you are undergrads. Maybe some of you are in a gap year or in a master's program, but it's really important that you figure out your best study practices now. Um, you know, I don't want to, gas myself up, but I didn't have to study very much in undergrad or high school. It was pretty straightforward. I knew how to work the system. I knew what I needed to study and how much I needed to study, and it wasn't too difficult. Dental school is difficult, even for the smartest people, especially if you want to do a specialty or you want to be towards the top of your class. It can be very, very difficult. So I knew what I needed to study within my first year. I knew that I needed to be in a public place with other people around me, um, preferably studying with someone else, but different topics. Like I didn't want to talk about what I was studying about, but I needed to know I had a friend there, and I needed to be in a crowded place with lots of people and ambient noise, and preferably with coffee. So I could get like 3 cups of coffee. Like that's how specific I knew. I had friends that knew they need to study at the specific library in the specific cubicle with headphones on, listening to specific soundtrack. Like you got to know how you're going to best retain information. And if you figure that out now, even though times are easy, then you're going to have a lot easier time in dental school when you have to prioritize and have to make the most of your effective studying time. The other thing I want to encourage you to do is figure out who you are now. You're never going to have the opportunities like you do in undergrad. And it's really tempting to say, I want to be a dentist and that's my identity. I'm going to put on the blinders. I'm going to do pre-dental club. I'm going to shadow a bajillion hours. I'm going to work in a dental office and I'm only going to have dental experiences to make my application as good as possible. And while that's great, and while that will make your application strong, I want to encourage you to do things that put you outside of your comfort zone, that encourage you to develop yourself personally and not just as an applicant. Because at the end of the day, you want to figure out who you are in life, and there's so much more to your identity than your work. As a professional, yes, when you describe yourself, your job may be one of the first adjectives you use, but you want to have other interests and other things that make you happy. Because if work is the only thing that makes you happy, then you're gonna become pretty jaded and pretty burned out pretty quickly. So in undergrad, I did do some pre-dental stuff, but I was in a fraternity. I did homecoming court. I did Relay for Life. I regret not doing longer study abroad. I did a study abroad service trip to Nicaragua. I regret not doing more. I did service trips. I went to football games. I did a lot of personal development. That I took whitewater rafting class, and yeah, whitewater rafting is not going to help me as a dentist, but it was really interesting, and it made me learn a lot about myself, and it provided me a lot of joy. And so I really encourage you that if you're one of those people that really wants to get into dental school and your blinders are on and that's your only focus, I want to encourage you to maybe try like one thing that isn't dental related. And that's really going to help you figure out who you are. And I have a point down here at the bottom that it's important to be well-rounded, to be a whole person. And that matters to dental schools. I volunteered with admissions at Ohio State when I was a dental student and admitting people. And yeah, it was great if people we want you to have a genuine interest in dentistry, and we want you to show it, but we also want you to be a human being. We want you to have interests. We want you to be passionate about something, because the people that don't have passions outside of dentistry, it's kind of a red flag. Like, are you a robot or are you someone that has interests? And that kind of ties into take advantage of unique experiences only available to you now. You're going to hear a lot of people opine and say, I wish I could have been an undergrad forever. And I definitely feel that way. There are so many unique experiences, even in the COVID era. It's easy for me to say back in my day pre-COVID, and COVID certainly has shaken up the landscape, but there are still so many unique experiences that are only available to you now. And I will say this online shadowing thing is really awesome. This is a really great experience. And I would encourage you to listen to some of the specialists, listen to the endodontics and the periodontists and the orthodontists, as well as the general dentist, because, they're going to provide a unique experience to you. And my ultimate theme is carpe diem. Life is meant to be lived, and I think a lot of us fall into that driven category, and I'm definitely one of those people where you're always working towards the next goal. It's always, oh, I need to get this GPA so that I can get this. I need to get this score on the DAT so I can get into dental school. And then when you're in dental school, it's I need to go to the lab and work on this. I need to study for this test. I need to get this GPA. I need to have these experiences so I can apply to a residency program. And then when you're in residency, you say, oh, I need to do this so I can get a job. I need to do this for my residency program. I need to publish this paper. And if you're always worried about what's ahead of you on the road, you're going to miss your experiences. And I definitely am guilty of this. But it's something I actively try to do. You want to enjoy your life because, you're going to blink and then all of a sudden it's going to be gone. And studying and dental school, it's tough. But there are things to enjoy, both in dental school and outside of dental school, that you want to make sure that you take time to appreciate. Go on that trip once it's safe to, and once you're fully vaccinated. Uh, do that service experience that you wanted to do. Um, go skydiving if that's something you want to do. I definitely don't. Go to the movies if you enjoy going to the movies. Go to a concert. I would say get good at time management so that you can say, yes, I will do this. Yes, I will go to the concert. Yes, I will go on this trip, because you're prepared and you've scheduled accordingly. Make sure that you have free time and you schedule in free time for yourself, because that's really important for your mental health. So that's kind of me espousing my wisdom, even though I've only been out of residency for a year. I'm still definitely young and early in my career, but I did include a few cases, and this is going to be different than general dentistry because this is going to be crazy mouth cases. And this is taken from some of my dental school lectures. I am going to do the Talk to Me Like I'm Five version, the Reddit version. So I don't know if there are any dental students or dental professionals on the call. I do apologize if I do simplify this too much, but I want to make sure that I don't lose anybody that doesn't know the dental lingo. So this is a case from the New York area. This came from a local oral surgery program, and it's a Hispanic male that recently immigrated to the United States from a Central American country. And he presented with a swelling on the left upper lip. And this case is featured on my YouTube channel. That's another plug. I am trying to grow it, so like and subscribe and share and all of that other stuff. Help me with the YouTube algorithm. So anyways, this is the case. This is what he looked like. And you can see the extra oral picture that there is, let me see if I can get my annotation, a little bit of fullness here. And you can definitely appreciate a bump as well. And this is a really common appearance that we see in our practice. There's something called a fibroma that happens when you bite on your lip or your cheek, and it's very common. It's one of the most common things that we see in our practice. And so that's probably what this looks like. That's what I would suspect that this would be. I'm not going to share with you something common. Of course, I'm going to share with you something really cool and exciting. So it's obviously not that. So that oral surgery program did the biopsy, which I would be comfortable doing that biopsy if it was in my practice. And this is what we see. We see this kind of, can you see my mouse? When I
Yeah, I
move?
can see it. I can see it.
Oh, okay, good. So I'm not gonna draw. We have this kind of weird cystic lining and then this red thing. You can see this red line going down the back. That's actually a notochord of this right here. So this kind of dark red line in the middle is a notochord. And on the biopsy section, we have this really dense cyst lining, and then we have intestinal mucosa. So why is there intestinal mucosa in a upper lip? Well, it's because this patient had cysticercosis. And cysticercosis occurs when the Tenuis solium larvae, which is the pork tapeworm, gets embedded in the muscle. Now, for most people that get a tapeworm, they are eating contaminated meat, most often pork. So the pig drinks contaminated water. It goes, the little larva goes through the blood into the pig's muscle, and then the human eats the muscle, and that oncospore kind of hatches in the stomach and creates the tapeworm, which we can see here. That's the tapeworm that we traditionally know. Now, in underdeveloped countries, the water processing systems aren't quite the same as they are in more developed nations. And so in this case, this patient was the pig. And the patient drank the contaminated water, and the oncosphere went into the muscle of the patient's upper lip. And the patient had a tapeworm in their upper lip. This condition can be seen in the brain, and it's really impressive. You can Google cysticercosis and see some MRIs of the brain, and it's like bullet hole, like Swiss cheese brain. And these are all little tapeworm larvae in the patient's brain. And you can also see it in the skin as well. So definitely, and by the way, I am a dentist. So this is not your typical presentation on Crown and Bridge and all on four and beautiful composite restorations and CAD CAM and CIRAC. This is a tapeworm in someone's lip. One of the really cool options in the dental field. So the next case I have is a 56-year-old male who has dysphagia. And dysphagia is the fancy SAT word for difficulty swallowing. And he also had a suspicious neck lesion or mass that was picked up on a head and neck exam by a dentist. And so this patient was sent for imaging. This is a CT scan, and we can see that there is a mass here. This is the base of the tongue, and then this is a lymph node in the neck. This is our vertebra in our spine. This is sternocleidomastoid muscle. And then over here, we have a PET scan, a positive positron emission tomography scan. And that takes radioactive glucose. And we know that cells that are actively dividing use glucose. They need ATP for mitochondria, the powerhouse of the cell. But they need ATP and they need glucose to divide. And so tumor cells pick up more of that radioactive glucose, and we can see that on PET scan. So this is normal tonsil tissue because the tonsil divides a little bit, but this is abnormal tissue at the base of the tongue. This is the mandible here, and then this is the lymph node. So this person has a base of tongue mass and a neck node. Under the microscope, we see this is the normal tissue of the base of the tongue, our squamous epithelium. And then we have all of these dark blue islands down here. We take a closer look at that and we have some kind of angry cells that are here that are kind of creating these streaming school of fish-like areas. This pink right here is necrosis, which means that the cells are dividing so quickly that they're dying. And that's not a good thing. This is a cancer. This is a specific type of cancer that this is a very classic presentation called HPV-related oropharyngeal squamous cell carcinoma. And this typically happens in men that are in their 50s or 60s. It is related to oral sex practices. It can happen in women as well, but we see it most often in men. And it often presents as a big neck node first before a tongue or tonsil biopsy. So tongue and tonsil is where it occurs as the primary site, and then it metastasizes or spreads to the neck, and you usually have a really big lymph node in the neck. This is usually treated with radiation and chemotherapy, and it has a really good survival, 70 to 80% 5-year survival. This is outside of the oral cavity. This is not in the tongue or in, it's in the tonsils and the base of the tongue, which is past where you can see only. But dentists can pick up this neck node, this really big neck node. And in addition, one thing that dentists can do that I advocate for is Gardasil vaccine, the HPV vaccine. And there's now a nonavalent or 9-valent vaccine that covers 9 different strains of the human papillomavirus, and that can actually prevent cancer. So not just cervical cancer in women, which is kind of what it's been advertised as, but this tongue cancer and tonsil cancer in men. It can prevent it. And so that's something really cool to think about as a dentist, that you may actually pick up a cancer like this. And then in addition, you can have conversations about systemic health, like, you know, is your child vaccinated? This vaccine is approved for people between the ages of 9 and 45. So if you are not vaccinated and you're on this call and you're interested in preventing this cancer, you can still get this vaccine. And I recommend talking to your healthcare provider about it. Talk to them about wanting the Gardasil vaccine. And even if you have been sexually active, it doesn't mean that, number one, you've been exposed to any strain of the virus. And number two, you've been exposed to the strains in the vaccine. So it's still a good idea to get vaccinated. And I really do encourage all of my patients to do so. In addition to the COVID-19 vaccines, which I really would encourage everyone. As a little aside, I did do my residency. I was in this hospital in March of 2020 when it really became very difficult in New York. And our office is located next to the morgue. And so we would walk by the morgue and they ran out of room. And then they ran out of room in the refrigerated truck out back. So I was literally passing bodies of people's loved ones going to work every day in March. I'm not going to valor steal there. I have plenty of friends that were working on the floors, and they truly are the heroes of the pandemic. I was only going in once a week. I did offer to help out in the morgue. We do autopsies as part of our residency, but they got to a point where they were so inundated that they stopped doing autopsies, and they were focused solely on storage and post-mortem care, getting bodies to funeral homes and coordinating that effort. So I will say that if you didn't live in the tri-state, or you didn't live in, El Paso later in the pandemic, or Florida, or other California or Washington at the beginning of the pandemic, and you didn't experience COVID firsthand, I will say, please encourage anyone in your life that is not vaccinated to do so. 99% of cases now are patients that aren't vaccinated. And this is real. This is a real thing, and I'm sure I'm preaching to the choir here, but it kind of blew my mind to see people downplaying the pandemic when I was walking into work. Number one, not sure if I was going to get sick, and number two, walking past dead bodies in the hallway because there wasn't room in the morgue. Not to be morbid and not to be Debbie Downer, but I did want to put in that little public service announcement that please encourage your loved ones to get vaccinated. This is truly a crisis, and it's not over until we get to herd immunity. Anyways, back to cases. That was my aside, and hopefully everyone on this call already knows that, but I digress. This is my third and final case. This is a case that I actually saw, and I did the biopsy. This is my suture right here. It's a 70-year-old female, and this is a patient that I was called to because she was admitted to the hospital because she lost 40 pounds, because she couldn't eat. She was dehydrated, so they had to put her on an IV, and that's because she had all of these sores in her mouth. So we can appreciate, I'm going to get my annotation, that there's some redness here, some red and white here, some red and white here, some red and white here, red and white on the lip, red and white here on the attachment of the tongue tie, the frenum. And she was basically just sloughing her mucosa, like shedding her skin. Like if you touched it, it would just peel right off and leave a bleeding surface, and it was incredibly painful for her to touch, let alone eat or drink. So under the biopsy, this is what the biopsy looked like. And unlike the squamous mucosa that we saw in the last specimen, we can see that there's a split here where the top of the mucosa is there, and we've got a single row of epithelial cells here. Now, this might look a little bit different, and that's because this tissue was frozen. And we know that there's water in cells, and water can distort the cells, and that leads to kind of like a freeze artifact where the water in the tissue kind of makes the tissue look funny. The reason why this is frozen is we did a special test called direct immunofluorescence. Direct immunofluorescence requires a special microscope that uses a special kind of light to look at antibodies. So we look at the patient's antibodies, which we have all heard a ton about. Antibodies are substances that our body makes to fight off bacteria and viruses. But in the case of autoimmune diseases, it fights off our own cells. And so in some conditions, we're looking for the patient's antibodies to see where they're fighting their own cells. And on direct immunofluorescence, we can label these antibodies with things that glow. And if you notice, between these cells, we've got this kind of glowing lines, like maybe you can appreciate it kind of here. It looks maybe like a fence, like a wire fence here. You can see it glowing between the cells. And this is characteristic of a condition called Pemphigus vulgaris, where certain antibodies attack the oral mucosa and causes it to peel off, where the connection of the skin, the oral mucosa, the lining of our mouth is attacked, and then it just peels away. It is extremely painful, and it can be so bad that patients will be admitted to the hospital sometimes because they can't eat or drink because they're in so much pain. And before the invention of steroids, patients would die from this condition. And it can affect the mouth, the nose, the genital mucosa, the anal mucosa, the eyes. It can be the skin. It can be a really painful condition. The treatment is high dose steroids. or monoclonal antibodies, which is emerging as treatment in cancer therapy as well as other conditions. This is my patient after 6 weeks of 60 milligrams of prednisone, and she's completely clear. So you can appreciate that, she was looking like she might be in rough shape here. And then I was able to really help this patient out. So, dentists do a really important work helping patients out with dental disease and periodontal disease. And then I get to do really cool things with systemic diseases sometimes and other mucosal disease. So I am a dentist. I went to dental school, and I get to do all of this really, really cool stuff that maybe you didn't know a dentist could do. And there's only about 250 of us in the country that do it. So I'll get to my conclusions. My advice to all of you: don't be afraid to try new things or change life directions. And that harks back to my earlier conversation that you want to be a well-rounded person and you want to find things that make you happy. And definitely you want your work to bring you happiness. Mine certainly does, but my work is not the only thing that brings me happiness. Um, and so I really make sure that I make time for things outside of work. And then also don't be afraid to change. So a lot of people will say, I posted on social media, I told my family and friends that I was going to be a dentist. I was like everybody else, probably going into dental school. I wanted to be an orthodontist because I loved my orthodontist. And ironically, orthodontics was my least favorite didactic class. I hated it. It was awful. God bless the orthodontists. I'm happy that they're happy, but I could never be an orthodontist. It was not for me. It's great. It's important. I'm glad there are people out there that do it, but I'm glad I'm not one of them. And so I changed life directions. I thought about leaving dental school because I didn't want to be in a career that made me miserable. And so I'm encouraging you not to be afraid to. And if you're lucky and you find that you love dentistry, that's awesome. That's great. Do it forever and be good at it. But if you want to try something else, if you want to try a specialty, don't be afraid. Ask for shadowing experiences. See what's available for you now with COVID going on, and once COVID's over, reach out to people. They'll be more than happy to share their experience. I love talking to people about my job because no one knows what I do. I've got my elevator pitch like down. Whenever someone asks what I do, I've got it like set. Like, I'm a dentist, but I don't do dentistry anymore. I diagnose conditions of the oral cavity, both in patients and under the microscope. Like, bang. Um, and then define your own success. So I when I found that I didn't like dentistry, I was really struggling, and that was kind of the first time in my life that I was really struggling with academics and with school. I had a really tough time with preps. Eventually, I was good. I did good work when I was a dental student. It just didn't bring me fulfillment. Um, but you want to define your own success. Don't let, especially in the age of social media. And a little disclaimer: I'm not the biggest social media fan. I do my social media for educational purposes to try to teach people. But the whole clout thing, that can be really hazardous to mental health. And when you're judging yourself and your own success based on other people's standards, you're always going to be reaching for somebody else's version of happiness. So try to find out what you want to do. What are your goals? What will you have to do to consider yourself successful, and then do that. And then lean into what you like and what you're good at. So I kind of followed what I liked and what I enjoyed and what I excelled in, and my path led me to a career that I love. And so lean into it. So if you find in dental school that you love dentistry, but you really like root canals, lean into that. So maybe you want to be an endodontist, or maybe you want to be a general dentist that focuses on endo and that does a lot of CE in endodontics. But I really encourage you to follow your passions and the things that make you excited. And that's what I did. I kind of said, screw it. I'm not living up to outside pressure. I'm going to change my goals now that I have more information, and it led me to where I am today. So that's all I've got. Definitely check out Dental Shadowers Instagram. That's how I found them. I really appreciate them having me on. Thank you guys for having me on. Another plug for my new Instagram. You can teach me the ways of social media. I post educational content, and then also my YouTube videos. I try to post once a week, and they're around 10 minutes, little snippets of either cool cases or really important things in oral pathology that I think dental students and pre-dental students should know.
Thank you so much, Dr. Roth. It's not every day that we have speakers like yourself. That was an extremely informative session. So I know we have a lot of questions in our chat. So Ibrahim's going to go ahead and read a couple of them.
Yeah, so let's get started with the questions. The first question is asks, what was the most ambiguous bump or growth that was directed to you?
The most ambiguous? I don't know about ambiguous. I've had some stuff. I actually had a really interesting case recently that blew up on Reddit, and that I posted a YouTube video about, where a patient of my boss had this thing on his palate, and we weren't sure what it was. And this patient has a history of 4 cancers: colon, stomach, double lung cancer, cancer in both of his lungs, and kidney cancer. And so we were initially really worried about metastatic cancer, which you can see in the oral cavity. You can get cancer that travels to your bone or to your mandible or to your gums. But my boss was able to take a pair of pliers, and he pulled out this white thing. It was like this braided plastic thing, and we had no clue what it was. And so I actually took that and I posted it to a subreddit that is "What is this thing?" I don't know how I had heard of it, but I had seen like posts of people posting weird stuff that they come across outside, and they would get answers as to what it was. And within 16 hours, we had an answer as to what it was. So if you want a little plug, I'll make you work for it. If you want to hear the whole story, you got to check out the YouTube video. That's a little plug. But it was a really cool case. But I see a ton of really interesting stuff. My first month of residency, there was a 25-year-old girl walking off a plane at JFK, and she broke her leg just from walking. She had a cancer called multiple myeloma. And multiple myeloma is something that we see in 50-year-old men. You do not see it in 25-year-old women. And she had a huge palatal mass as well. But a lot of times, if we see a bump, we don't really know what it is until we look at it under the microscope. And that's why it's really cool that I get to see patients clinically and then get to see them under the microscope. So I had a patient yesterday. She had a white patch, which is either cancer or precancerous. And then I got to see it this morning. I did the biopsy yesterday, and I looked at it this morning, and I was able to see both the clinical and the histologic presentation of this patient and correlate them together. So a lot of times we don't know for sure. There are some things that we know what they are by looking at them, and there are some things we're not really sure until we take a biopsy and we look at it under the microscope. So every bump is ambiguous.
Sounds good. Thank you for that response. Next question is, when you were in dental school, where were you able to balance being in clubs and residency while managing schoolwork? How involved can you get while in dental school?
So residency was after dental school. So I graduated from dental school and did a residency. The shadowing I did a lot during my 3rd and 4th year, which is predominantly clinical care. And if I didn't have a patient, I would go shadow my mentor in either her clinical practice or at the microscope. But that really revolved around my patient care activities. And I was really fortunate to have really good clinic directors that kind of encouraged this passion, that allowed me to shadow. So in dental school, in the clinical years, there tends to be a lot of waiting, a lot of no-shows from patients. And that's really a good opportunity to either help a classmate with assisting or to pursue shadowing opportunities within the college. As far as clubs and other activities, I wasn't too involved in dental school. I was really involved in undergrad. Dental school, I spent a lot of my free time just decompressing, like watching movies, hanging out with friends. I worked in my D3 year of dental school for fun. I'm a huge craft beer nerd. And so a bar called World of Beer opened on campus. And I did it for fun because I love talking about beer, and I made some extra money. And that's because my D3 year, I wasn't really stressed with board exams yet. I was still building my patient practice. The didactic portion, which is exams and lectures, was kind of slowing down. And so that was a really good window, but it's difficult. And so time management is really important. And again, same thing with studying. I recommend getting your time management skills down now so that you're prepared in dental school to do clubs and other things that outside of dental school that make you happy.
Sounds good. Thank you. The next question is, how are dentists able to spot the carcinoma? Is the neck mass that large?
So in that specific case, that's kind of a weird case that a dentist may not be the first person to do. A dentist did happen to find that one. Oftentimes a physician will find that. The neck mass was that large, yes, but you do take oral pathology courses in dental school. I teach one of them at Toro College of Dentistry for now. And a lot of these courses are in training dental students to recognize what's normal and what isn't normal. And if it isn't normal, then you got to try to figure out what it is. And if you can't figure out what it is, you either biopsy or you send it out for biopsy. So carcinoma in the oral cavity can look like a lot of different things. It can look like an ulcer. It can look like a white patch. It can look like a huge fungating mass, like an ugly fungating mass. It can look like a lot of things. And so a lot of the dental school curriculum, or some of the dental school curriculum, is spent really getting comfortable with what different things look like. But at the end of the day, if dentists are concerned, then they refer it either to me, to an oral surgeon, to a periodontist, and then using our experience, we will biopsy it or we'll watch it. But there's a lot of things. Cancer can look like a lot of things, a lot of different appearances. And I will post some clinical photos of cancer as I come across them in my Instagram. I have a ton. I'm very much a case hoarder. So you only saw 3 of my cases. I probably have 500 cases on my laptop of really cool things that I came across in residency, both under the microscope and in people's mouths.
Wow, yeah, that's really interesting that you keep all your cases and everything still.
I'm a pack
Okay,
rat.
so our final question is, do most oral and maxillofacial pathologists work in a hospital or in a private practice setting?
Yeah, so most oral and maxillofacial pathologists work in a dental school. I would say probably maybe 75 to 80%. Then the next is hospital, and there's really not too many of us in a hospital setting. And then there's like 5 that work in a private practice. The reason is microscope slides have quite a bit of overhead. And so a lot of people that look at microscope slides are associated with a hospital that processes microscope slides for general pathology, or a dental school that's attached to a hospital that processes microscope slides. There are quite a few private practitioners that see patients, and then there are some people that do research. So it's a variety, but the vast majority are in dental schools. And the reason is it's so important, as I just discussed, for dentists to be trained in this stuff in oral pathology. And since there's so few of us, it really falls on us to provide these educational opportunities. So it's really, really important that we're out there giving CE, we're out there talking to dental students, we're out there talking to dental hygiene students. I made my YouTube as part of that, trying to reach out to make sure that there's awareness that, you know, this is a part of dentistry, and you don't want to be that dentist that misses a cancer in someone's mouth, because that could be life or death. There's only 2 ways to kill someone in dentistry. Number 1 is through medications. Prescribing the wrong medication, giving someone too much anesthetic. And number 2 is missing a cancer. That's the only 2 ways that you can kill somebody. And so it's really, really important that in your dental school training, you get adequate oral pathology training, or you seek out adequate oral pathology training.
Thank you so much. So unfortunately, it looks like that's all the time we have today. Dr. Roth, thank you so much for joining. That was extremely informative. And I want to tell everyone to join his YouTube channel. I'm sure he'd love that. And I want to thank everyone for joining today's session. You can find our quiz on our Linktree or our GroupMe. But on that note, thank you everyone for joining, and I wish you all have a